Well, good morning, everyone. I just want to say thank you for choosing to spend your very early Thursday morning with us. As you heard, I'm Dr. David M. Carlisle, President and CEO of Charles R. Drew University of Medicine and Science right here in Los Angeles, and it is indeed a pleasure to welcome you to the 10th Annual CDU President's Breakfast presented by LA Care Health Plan. And before we get started, I do invite you to visit our website, cdrewu.edu/breakfast, and click on the program to view today's program and learn more about today's speakers and sponsors. So every fall, we spend several weeks proposing and considering possible themes for this highly anticipated annual event. The list of contenders, as far as ideas are concerned, often reflects the diverse interests, affinities, and scholarship of our colleagues, our students, and our alumni, as well as national trends and the concurrent political landscape. For the last 9 years, the President's Breakfast speakers and panelists have engaged in thought-provoking, controversial, and inspiring dialogue that reflects on their topic's history, takes an inventory of the challenges faced and the progress made, and outlines the work ahead. We intended to follow that formula when we chose this year's topic. Health disparities, are we better now? That was before January 20th. And for the first time in 10 years, the CDU's President's Breakfast will also address the very real possibility and consequences of losing ground and regressing on a critical societal issue and human right. The reluctance assigned to health disparities is not new. When I started my work as a research fellow at UCLA in the 1980s, my well-meaning advisor suggested that I focused on something other than disparities research. Not because it wasn't important work, but because it had already been done. And they thought it would have been easier for me to propel my career forward and earn recognition for research in an area that was, quote, more innovative and groundbreaking. I, on the other hand, doubled down on my work because, as a medical doctor here in Los Angeles, I had witnessed firsthand the realities of health inequity and knew there was more work to be done. And just a couple of stories to share with you. As a resident at Harbor UCLA Medical Center, and there are probably some Harborites in the room here, I had the pleasure and distinction and privilege of taking care of a member of the original Drifters that sang Under the Boardwalk. And I used to hang out with him in his room, late at night, 2 o'clock in the morning. I'd walk by, he'd be awake, I'd sit down, talk to him before he passed away. And that told me, conveyed a message. Here is one of the cultural icons of the United States, who really set the cultural trajectory of the United States for many years, a national hero, and he's spending the last days of his life in a safety net hospital without health insurance. Another story. I had a patient I took care of in the emergency room when I was an intern for a social disease. And then when I was a chief resident, I got a call from the resident in charge of the emergency room one afternoon. And he said, Dave, there's a young guy here asking for you. And I said, this is 3 years later. And I said, well, okay, what's his name? And the chief resident said his name, and I said, I vaguely remember this name. I'm not sure why, but I do. And the resident said, well, you need to know his chest x-ray. Looks like he's got metastatic testicular carcinoma. If you know x-rays, it has a typical x-ray pattern. And I said, oh, okay. Went down to see this gentleman, and I said, tell me what happened. How did you end up in this situation? And he said, well, I noticed something was wrong. Had an idea of what it was. I went to see a urologist, and the urologist was very accommodating. He said, yes, early stage, you picked it up early, we can cure you. Do you have health insurance? The answer was no. The urologic care stopped. And about a year later, the patient presented in the emergency room with metastatic testicular carcinoma and died less than a year later. Another story, and this is a great LA Care story. I was at a restaurant that I frequent. I was talking to one of the waiters that I knew, and I said, excuse me, but let me ask you a personal question. And she said, sure. And I said, what kind of health insurance do you have? And she said, I have LA Care. And I noted that she didn't say Medi-Cal. She said LA Care. And I asked her, what do you think about it? And she said, effusively, I love it. And I was reflecting on the difference over time between when I was a resident and here we are today, when so many more people have health insurance. And I asked her, why do you love it? And she said, well, you have to understand, I was uninsured. I never had health insurance before. And now, because of LA Care, I'm insured. And furthermore, everyone in my family has LA Care health insurance. I love it. So I just want to, before we move on, acknowledge the generosity of our presenting sponsor, LA Care Health Plan. LA Care has been a long-time CDU partner, and we're ever grateful to have their support. Of course, their former CEO is the chair of our board. John, do you want to stand up and be acknowledged? John Bacchus. And now I'd like to invite the current CEO, Martha Santana Chin, to the stage to give remarks. Martha.
So good morning, everyone. What an honor to be here today. And Dr. Carlo, thank you for inviting me to this very important conversation, especially given everything that's happening at the federal level that has the potential of significantly impacting the work that we do here in the county. Again, I'm Martha Santana Chin. I'm CEO of LA Care Health Plan. And it's great to see so many familiar faces, and also I look forward to connecting with some of you who I've not met before. I am just delighted and honored to share this space with the Honorable Javier Becerra, Dr. Braverman, Dr. Hayes Bautista, and Ms. Haynes. These are all individuals who have dedicated their careers to really advancing health equity, and we're very fortunate to have them here today to talk to us a little bit about what's happening and their perspectives. LA Care is proud to be the nation's largest publicly operated health plan, serving over 2.6 million members, including 2.3 million Medi-Cal enrollees. We also provide coverage through Covered California and through a Medicare special needs plan, as well as covering over 50,000 in-home supportive services workers who dedicate their lives to supporting some of the most underserved individuals and under-resourced individuals in our county. And our role extends beyond healthcare delivery. We really see ourselves as a health equity advocacy organization, as well as an organization that has a responsibility to advance and support justice, social justice. And I'll start by just asking us to reflect a little bit about the remarkable progress that we have made in the city of California over the last several decades. 15 years ago, 20 years ago, who would have thought that we would be at a place where we can say that over 90% of Angelenos are covered by some form of health insurance? Thanks to the Affordable Care Act and to the California expansion of our Medi-Cal program to include all individuals in the state, including those that may not have satisfactory immigration status, we've made progress. We've advanced through coverage, expanding access. And that coverage and access has really resulted in more people having access to preventative services, to mental health services, and we are building infrastructure to really address social drivers of health in earnest by using Medi-Cal as a tool to do just that. We've also made significant investments in our workforce. I'm going to ask you all to give a round of applause again for Mr. John Bacchus, who started this work at LA Care that I now have the privilege to continue. So Through our Elevating the Safety Net initiative, we provide full ride medical school scholarships to students attending Charles Drew University and UCLA, and that is helping us to recruit. And that is helping us to recruit individuals from underserved communities to go back and serve as primary care providers in the very neighborhoods that have a shortage of providers. So we're very proud of that work. Another example that I'd like to share with you is the work that we're doing to provide non-emergency medical transportation. LA Care supports over 400,000 rides every single month. And historically, that was a significant barrier in accessing healthcare for many of our low-income communities. Again, that's an advancement that has been made available through the progress we've made in policy and benefits and coverage here in the state of California. Today, we are in a situation where federal proposals to cut Medicaid funding, impose work requirements, and shift responsibilities for covering these services to the state are threatening Medi-Cal's stability. And these changes will reduce coverage, impact benefits, limit access to care, and potentially force us to eliminate critical services like dental and vision care. So this issue and this moment is a very personal one for me. My family grew up struggling financially, but Medi-Cal gave us the stability to allow me to focus on my education and the future. And that support really shaped who I am today. So I can't stay silent at this time when these vital programs are threatened, and so many in our community depend on them. And I know many in the room know this and appreciate this and embrace this, but the more that we can get the word out, healthcare really is not a partisan issue. It's a human one. And we have a responsibility to work together to protect our charge, to support our communities. And LA Care remains committed to doing just that, advocating for equity and collaborating with community leaders, policymakers, and healthcare providers to make sure that Los Angeles County is delivering more equitable care. And so our ask of you today is to move forward with us in partnership, locking arms, with compassion, with focus, and with resolve. Let's stand united to serve our communities and ensure that every Angelino gets the care they need and deserve. Thank you.
Let's give another round of applause to Martha Santana Chin and LA Care Health Plan, the biggest Medicaid health plan in the known universe, right here in Los Angeles. And I dare say that that young gentleman that I mentioned who passed away from the testicular cancer, if that had happened today, I'm sure he would have had LA Care, and he probably would have survived his illness. That's how transformational this is, and that's how it ties into the whole topic of health disparities, because there are people who've lost their lives because of disparities in healthcare, and there are people today who are going to be living long lives because of the work that people like LA Care are doing to eliminate healthcare disparities. So again, thank you to Martha Santana Chin, our LA Care CEO. CDU is also grateful to our gold sponsors, Common Spirit, Torrey Pines Bank, the Weingarten family, our friends at Cedars-Sinai, and everyone else who's contributed to making this a great event. And year after year, we appreciate your support. A special thank you to CDU's Chief Finance Officer, Elizabeth Baskerville, for supporting this event with a Ruby sponsorship. Liz, thank you very much. And now it's my distinct honor to recognize today's keynote speakers, someone who has dedicated his entire career to public service and has directly influenced health access and equity in the United States. Javier Becerra started his career as a legal advocate for individuals with mental illness before serving 12 terms in the U.S. House of Representatives. As a representative for California's 30th, 31st, and 34th congressional districts, and I'll add right here in Los Angeles. Mr. Becerra championed key healthcare reforms, including co-sponsoring the Affordable Care Act and strengthening Medicare while reducing healthcare costs for seniors. In 2017, Mr. Becerra became California's Attorney General, and during his tenure, he played a critical role in defending the Affordable Care Act and reproductive freedom, suing the previous Trump administration more than 100 times on behalf of Californians and standing strong for California values. In 2021, Mr. Becerra was appointed the Secretary of the U.S. Department of Health and Human Services, the first Latino to hold that post, where he was proud to lead the administration's efforts to reduce prescription drug costs, allowing Medicare to negotiate directly with drug companies. Please join me in welcoming the Honorable Javier Becerra to the stage, our LA hero.
Good morning. Thank you for taking the time to be with us today. I want to thank President Carlisle. I'm going to wait till our panelists take their seats as well, because we're going to have a great opportunity to hear from true experts on diversity and equity in just a moment. But I want to begin by thanking the team at Charles Drew University of Medicine and Science, because if anyone is living these challenging times, it is Drew. If anyone is trying to figure out how to navigate these challenging times, it's the students who've come here and are trying to figure out what their future will hold. And if there's anyone who feels the attacks more than anyone, it's those students who are first generation medical students, the first in their family to have an opportunity to be in a professional study, the first perhaps in generations to actually get to have a professional title. And so for them, I think it is important that we take on this assignment. But I have to tell you, there's, as tough as sometimes the news is, there is some good news. You didn't probably read about it, but you know, the Lakers just beat the Mavericks, and and the Dodgers have about every phenom in baseball that exists, and so there will be some good days. It's a good day. And we got to translate their victories into victories for ourselves here. So think like the Dodgers, think like the Lakers. We're going to win. Win, baby, win. And so here's what I think I would love to tell you. First, to our esteemed panelists who have been gracious to give us time because they are true experts on these issues, to President Carlisle and his team for giving me an opportunity to come as well. Martha is going to do some tremendous work, I know, with all the folks who live in the LA area in trying to follow John's footsteps and making sure that everyone gets the care that they need and access that they deserve to quality physicians and medical providers. And I think it is great to have all of this team assembled and some of us to answer some questions. But here's the thing. Do we take onto the field the attitude, or onto the court the attitude that those athletes do? That we have been going through some rigorous training, we read up on the playbook, we understand the coach's instructions, and now we're ready to deliver. Because we shouldn't be in that starting five. We should not be getting to be on the field if we haven't prepared ourselves. Because these attacks are going to come fast and furious. And we have to be ready. I would say something even more. Are there people here who are themselves the first in their family to actually have a chance to hold a professional degree? I know I am. Probably if I go back and ask you from your grandparents to today, how many of you can say that one of them, grandparents, parents, or you, are the first in your family to have that opportunity to have that professional degree? Yeah. And I suspect there are still some who, like Dr. Charles Drew, still got to experience the effects of not having been part of that crowd that got those professional degrees. You know, he never, for the entire time of his life, got to be a member of the American Medical Association. And so there are still people experiencing that. Not too long ago, one of our esteemed institutions, Cedars-Sinai Medical Center, had to resolve a civil rights complaint that we filed on behalf of a woman, African-American woman, who died because of the care that at least she and her family alleged that she received or did not receive. And we resolved that with Cedar, and we're pleased that Cedar was willing to resolve it. But what Charles Drew experienced is not only in the past. And so we need to bring our A game. In fact, I would put it a different way to you. We need to punch above our assigned weight class. Because people have placed us where they think we should be. And I guarantee you there were very few people who would look at this son of immigrants, first to have a chance to go to a university and say, he's going to become Secretary of the U.S. Department of Health and Human Services. The department entity, the enterprise with the seventh largest budget in the world. Not health department budget in the world. The largest budget only after, I believe, probably Japan and Germany in terms of size of the Department of Health and Human Services budget. Did they peg me as getting to do that? I doubt it. But sometimes you just have to be ready to punch above your assigned weight class. And so here's what I'm telling you. Read that playbook. Learn the lessons of the Charles Drews. Heed what a David Carlisle is saying to you, and listen to these folks who understand how to navigate this, because we're going to get past this. Because if we're true champions, we're going to join the Lakers and the Dodgers and say we did this, because we have no choice. Because if we don't do it, then that other family that's never had the opportunity to have their child go on to that college degree and beyond is going to wonder what the heck happened. So here's the only 2 points I really want to make to you as we get ready as part of the team to take to the field. One, and I'm going to give it by example. When I became secretary in 2021, March of 2021, everything was COVID, 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 COVID. You remember. You could not go out. You could not sit like this together without you could not sit together like this, right? You lost, many of you and your family lost their jobs. Because they lost their jobs, they lost their health insurance. Tough times. The economy was reeling. We sometimes forget because we've done so well since. About 3 months in, I started getting, because every day I was getting reports on where we were on COVID, what we needed to do. By the way, remember, the day President Biden took office, he inherited a country that was losing 10 jumbo jets of Americans filled every day. Let me repeat that. If you were to find out today in the news that a jumbo jet crashed and everyone perished, about 400 people, we'd say, oh my gosh. If you heard it was 2 or 3 of them in one day, you'd say, something's going on. If I told you it was 10, you'd say, it's not possible. That's what we were losing every day during the height of COVID. 10 jumbo jets filled with Americans. Essentially, 3 times as many people every day than we lost in 9/11. That's what we were going through. And so I was getting reports daily what we were doing. And here's the one thing that stood out to me, on top of the just challenge it was going to be to address COVID. We started to see what we always see in America, the growing disparity. By late May, about 2/3 of white adults in this country had received their first COVID vaccine. Less than 50% of Black and Latino American adults had received their COVID vaccine. So I said, we're not going to do that. We're not going to let that happen. So we did something that I don't believe we often do well as government or as the private sector. We didn't wait for folks to come to us to find the vaccine. We went to them. We went to the schools. We set up clinics in arena parking lots. We went to the fields and helped farm workers get vaccinated because they couldn't leave the fields. We went where you were. We talked to your school teacher. We talked to your wrestling coach. We talked to your beautician. We talked to the people that you trust, your religious leaders, and we asked them to be our voices. And that's how we reach so many people. So that by today, I can tell you that we have placed some 700 million COVID vaccine shots in the arms of Americans. And that is why today you get to sit here and listen to us and not worry about having to wear a mask or distance by 6 feet. It wasn't because it was accidental. It wasn't because we were lucky. And it wasn't easy. It was intentional. We intended to go find you who needed to get vaccinated because we know if we had just let things run their course, many of you, would not have gotten that vaccine, either because you thought you couldn't afford it, you couldn't leave your work, or didn't have transportation for whatever reason. And that was not going to be a good excuse. And so we went out, and we didn't wait for you to come to us. That was intentional. We also made sure that we found the things that we knew we could do so long as we talked to you. And so I'm going to give you one quick example of something we did, which I hope continues in this next administration because it barely launched. More and more, in a place like this, you know about this, gene and cell therapy is becoming more commonplace and very innovative and rewarding, but it's very expensive. Today, there's actually a therapy for sickle cell disease, which could actually lead to a cure for the 100,000 or so Americans who suffer from sickle cell disease and live through pain for their shortened lives in America. We came up with a program which we think is going to make that sickle cell therapy that could cure you available to those Americans. And see, it was really simple. All we had to do is think how we could do that. And what we've realized is that most of those people who have sickle cell are on Medicaid because they're not wealthy. That means that the government, state and federal government, which operate Medicaid, here Medi-Cal, we're paying for the treatment of those folks, not to get well and cured, to manage their pain, to live out whatever years they have in their life so they're not in excruciating disability. And it's costing a ton of money. So that those gene therapies, there's two of them. One costs $2 million. One costs $3 million. You got $2 or $3 million spare in your pocket to spend for that? Most don't. So what we said is, look, states, we're already paying for the treatment of the management of the disease. How about we do this? Let us negotiate with those two manufacturers of those therapies and get the best price, because what we'll do is we'll guarantee them the population as their clients. Otherwise, they're on their own trying to see who they can pick off, who can pay $2 or $3 million for that treatment, which will be very few customers. We guarantee them lots of customers. They guarantee us a much lower price. We save money at the end because we're not paying for years and years of pain management. Pretty simple concept. It was not rocket science. We've launched. It was not a coincidence that the very first disease I chose to have our gene and cell therapy model target was sickle cell. Because early on I had met with a number of folks in the sickle cell community who had said to me, you know what? We know we're a small number, 100,000 or so. We know it's hard for you all to pay attention to us. And we know that if you come up with these innovative cures, it's only going to be for a small population of the 330 million Americans. We know we're not going to get your attention. But we've been asking for the longest time. This is where it makes a difference who's in those positions, who's on the field, who's the starting five. And I told our team at NIH, if we get to the point where those manufacturers get clearance through FDA for their therapies, let's make sickle cell disease the first of the diseases that we try to conquer through this new model. And so that's where we are today. And now, so long as there's no disruption in Washington, D.C., that model will get to move forward. And tens of thousands of Americans may get to benefit, not just from pain management, but from a potential cure for something that's taking their life way too early. That was not a roll of the dice. That was not coincidence. And it wasn't luck. It was intentional. We need to be intentional in everything we do. The second thing I think I want you to understand is You can be intentional, but if you're late to the game, you can't undo a score. The Kansas City Chiefs were not going to overcome the Philadelphia Eagles in the fourth quarter, right? I hope you all play sports or enjoy them, because otherwise you're going to have to go home and, honey, what the heck was this guy talking about when he was talking about football and basketball? You just were not going to overcome that kind of a lead in the fourth quarter. You got to start early. And so I learned something when I was Attorney General in California before I became Secretary. California had passed an innovative law to protect your and my privacy over the internet, because these social media and internet companies were just gobbling up our personal information and selling it without our knowledge, without our authorization, and making tons of money. And so California passed the first in the nation law to protect your data privacy. I had to implement it as AG. And one of the things that my team member said is, we can be doing a lot of remedying. My mom used to always tell me, "Mijo, mejor prevenir que remediar." It is always better to prevent than to remediate. And so they kept saying to me, well, we could try to undo the loss of privacy. You can never undo the loss of privacy. Once your personal information is out, you don't get it back. And so I said, we have to change the paradigm here. We can't allow the privacy rights that people have and their data, personal data, to go out. What can we do? And that's where we came up with this concept, privacy by design. So anyone wants to go out there, market their product, their system, their social media, their internet service, for purposes of abiding by our new consumer protection law for your data privacy, they had to show us that in the design of their product, in the design of their system, they had incorporated equity to privacy to protect people's privacy in California. And so when I became secretary, essentially I said the same thing when it came to healthcare. Equity by design in all the initiatives we run. And by the way, the Department of Health and Human Services is the largest grant-making department in, I was going to say the U.S., but the world. We put up more money than anyone else. We contract with more than anyone else. And so when you want to contract with me, when you want to get one of my grants, show me in the design of your system, your service, your product, that you have incorporated equity into it, so that I know that you're not going to imbalance things the way we started to see, as I mentioned, with the COVID vaccines. And so that became our trademark, equity by design in what we do. So if you are intentional and you start with a platform that takes into account fairness and inclusion, you won't find yourself in the fourth quarter where the Chiefs were. And you will be in far better shape. And so I hope that all of us understand that we have an opportunity to make a difference. And I am thrilled to get to be here with you, because I think I'm speaking to people who understand this and who've lived it. And so let me close with a final thought, because this is a challenging time, but to me, this is not the real challenge. To me, the real challenge is, how do we get to a point where our health system actually reaches all of us and it cares about our wellness, not just our illness. We need to move from a system that treats illness to one that promotes wellness, where we think first about what you need to do to stay healthy, not what you now need to do to address your diabetes. That's where we got to go. And what I will say to you is, the best advice I ever saw, along with my mom's, it was another great American by the name of Frederick Douglass. He made a very simple statement that 170 years ago resonated and still today does. It is easier to build strong children than to repair broken men. We're repairing a whole bunch of broken men and women, and we're spending big money to do that. If we had spent the money to build strong children from the very beginning, can you imagine the might of this country? Even the Dodgers and Lakers wouldn't be able to compete with us. And so I say to each and every one of you, this is our time. The challenge is now before us. I don't look at Washington, D.C. and say, ooh, Mufasa. I say, I can take this one. I seen this before. My parents did way more than this. Because every day, when my dad would tell me, you know, son, if he would say it in Spanish, mijo, si puedo ir a trabajar mañana en la mañana, va a ser un buen día. If I can get up in the morning and go to work, it's a good day. Because, you know, if he didn't go to work, there might not be food on the table. So it was a good day. I'm having a lot of good days. And I'm putting food on the table. Well, my wife, who's a physician, puts more than I do on the table. But I will say this. This is not the hardest challenge we'll face. It's an obstruction. It's distasteful. It's making us remember what Charles Drew went through. But this is not the big game. We're prepped. We're ready. We've been through this. Our parents and grandparents were there coaching us. If we were listening and watching, they set an example. We're ready. We've got to prove it. And so I am thrilled to be here and thrilled to be with some distinguished colleagues who understand disparities and equity so much, because we're going to win this one. We may not have all the phenoms in the business, but we've done the work, and so we're ready. So thank you for inviting me to be here with you.
Well, thank you, Mr. Becerra, for your insight. Your words give us much to think about, of course, and certainly set the stage for our dialogue. Before I go further, I'm going to go off script a little bit. I'm looking at our Senior Vice President as I say that, our Director of Communications as I say that. And just to insert a few promos about Charles R. Drew University of Medicine and Science. And you think about us in the context of disparities. Our vision statement says, excellent health and wellness for all in a world without health disparities. That is our guiding North Star. Some examples about how we're achieving that vision. For example, we have the #1 ranked master's degree program in biomedical sciences in the entire country at CDU. Dean Farini. Monica Farini is our Dean of College of Science and Health, where that program is. Our new School of Medicine just is accepting its third class. Dean Prothero Stith, I know you're here. I didn't see you. There you are. Okay, great. That school, which has this year 6,252 applications for 60 slots, 100 to 1. And you know, when we opened 2 years ago, all by ourselves of the 13 medical schools in California, we increased the total number of African American first-year medical students in the entire state of California, all by ourselves, by over 20%. We also increased the number of Latino medical students in the state of California by over 10%. And, you know, frankly, I think that says more about California institutions than it says about CDU. But we're doing what we can do to eliminate health disparities. Most of our students, you talk to them, they are the first members in their families to go to college or medical school. Most of our medical students, when they were in college, 2/3 of them, twice the national average among medical students, were Pell Grant recipients in college. They didn't have mothers and fathers and grandmothers and grandfathers who are physicians. And all they want to do is become a doctor to go back to the community they grew up in and make it a healthier place. That is a CDU student, and that is Charles R. Drew University of Medicine and Science. So now I'm going to go ahead and share with you my favorite part of planning the President's Breakfast is reaching out to experts across California and the country with invitation to participate and always receiving an enthusiastic acceptance. Everyone on this stage said yes without hesitating, and I want to thank them for that. Dr. Paula Braveman. Dr. Paula Braveman is somebody I've known about my entire career. We actually haven't intersected too often, but I've certainly followed her work. because her work is a real inspiration for my own work as an academician. She's Professor Emeritus of Family and Community Medicine and the founding director of the Center for Health Equity at the University of California, San Francisco. For nearly 40 years, Dr. Braveman has published extensively on health equity and its social and structural determinants, including racism, and has brought attention to these issues in the United States and internationally. Throughout her career, she has collaborated with local, state, federal, and international agencies to see rigorous research translated into practice with the goal of achieving greater health equity. Her book, The Social Determinants of Health and Health Disparities, was recently published by Oxford University Press. Dr. Braveman. Dr. David Hayes Bautista. And I was just saying to David, I remember that morning, probably 40 years ago, when we had coffee together at a Starbucks just south of Westwood. I've known him my entire career as well. He is the Distinguished Professor of Medicine and Director of the Center for the Study of Latino Health and Culture, the famous Center for the Study of Latino Health and Culture at the UCLA Geffen School of Medicine. He served as founding executive director of La Clinica de la Raza in Oakland, California. Dr. Hayes Bautista's research focuses on the impact of racial narratives on research design and methods, including, for example, the use of 6 OMB race ethnic categories in researching health outcomes in our complexly heterogeneous state of California. For the past 6 years, his group has also produced the U.S. Latino GDP, which of course was the 5th largest economy in the world in 2021. David Hayes Bautista. And then there is Catherine Haynes, a senior program officer of the California Healthcare Foundation, where I'm on the board of directors. She runs the People-Centered Care Team project, which works to ensure that Californians, particularly those who are enrolled in Medi-Cal, receive responsive, comprehensive, and coordinated care that supports their health and well-being. Before joining CHCF, Catherine worked as program director at the Institute for the Future in Palo Alto, where she led systematic thinking about health and healthcare futures among executives of public and private organizations. Catherine also built Kaiser Permanente Northern California's diversity department with the mission to advance language access and health equity, and served as its executive director. So, please join me in welcoming our panel of experts. As we begin our panel discussion, let me remind the audience that we will open the floor to questions from the audience at the end of our panel. I will now join the panel. So the first question is for Dr. Braveman. Racism has been a central focus of your research. Can you discuss how structural racism continues to shape health outcomes, particularly in maternal and infant care?
Thank you, Dr. Carlisle, and thank you for inviting me to participate in this celebration of the university's illustrious history. I think when most people think about racism, they think of the sort of in-your-face interpersonal racism, the name-calling, lynching, other interpersonal violence that certainly is stressful, and the literature has documented that, even getting down to what some of the physiological mechanisms are that are involved. What people don't think about so much is the racism that is indirect, acts more indirectly, and is mostly structural. And an example of that, I think a good example of that would be you take racial residential segregation, and then you add to that the unfair bank lending. that gives people of color worse terms for lending. And what that generates then is lower property values in areas that are heavily populated by people of color. And since the United States, unlike most other affluent nations, funds its schools on the basis of local property taxes instead of on a per capita basis, which is what would be, per capita basis plus a consideration for need, that would be more equitable. So you have lower property taxes in places where people of color reside, for the most part. And then that means that you have under-resourced schools. And under-resourced schools then give kids who are growing up in the places with under-resourced schools, give them less economic opportunity. And less economic opportunity is going to lead to more financial hardship, and financial hardship will produce stress, greater stress, and also exposure to harmful physical conditions. So it's all these many steps, and I think that's one of the reasons why people don't recognize the structural factors, because there are these long causal chains, and it's not the direct, X to Y that we see with the interpersonal racism. But it's probably, at this point in our history, it's probably more deadly in terms of what its effects are. Most of my empiric research has been on maternal and infant health, and particularly on preterm birth, and the role of stress, of psychological stress in preterm birth is pretty well accepted. There's a consensus even among the more biomedical types. So you get a tremendous amount of stress that is generated by interpersonal racism, but you get also an incredible amount of stress that's generated indirectly through the structural racism and this long and often complex chain of factors that leads to a lot more health damage. And I think one thing that is good that is going on now is that there's more attention being paid to the structural factors in general.
Well, thank you. Going on to Dr. Hayes Bautista. In your work, you've examined how race and ethnicity are categorized in health research. Do these categories help or hinder our ability to address disparities effectively?
Well, actually, both. They're a help and they're a hindrance at the same time. Just to give you an example of how they might be a help. Some of you may be old enough to remember Ward Connerly's Racial Privacy Initiative that was going to remove all racial identifiers from driver's license, birth, death, you name it. You would never know anyone's race. Well, if that were the case, what would you use to try to discover inequities? What would drive things? So we could say, let's use income, but then high-income African-American women suffer from really high rates of maternal mortality, so you would miss that. We wouldn't see it. Or you wouldn't see the Latino epidemiological paradox, where in spite of low income, education, horrible access to care, Latinos will reduce the rate for heart disease by 30% and live 5 years longer. His initiative didn't pass, so we still use these categories. But now comes the hindrance part. So we're using these categories. We pick things up. Here's the black health profile, the Asian, the Latino, et cetera, et cetera. And we're using 230-year-old concepts that have this real strong idea of biological determinism. Because of your race, ergo, you're going to have these things. And part of that framework also assumes that you were born with a race, you live with that race, you die the same race. But here in California, we've never stayed on our racial lanes the way we're supposed to. And in fact, in 2015, over half the babies born in California had mothers and fathers of different single race groups. So, under which race do we record the birth weight of the baby, of the father or the mother? And that's half the population. Okay, so while we use these concepts, they're still also holding us back. So what we need to do is to create a new way of defining human samenesses and human differences, a way that's more fluid, more dynamic, that allows you to be a lot of different things all at once, and still has predictive power, so we would understand, well, women with a certain history, family, community, etc., is at risk for high maternal mortality, irrespective of income, or that another mom with a different background in terms of family, community history, in spite of low income, would have spectacular birth outcomes. We don't have that right now. What are we going to do? Suppose this current administration were to have an executive order, you can no longer record anybody's race. Boom, how do we find any inequities? We need to create a new epistemology to define human samenesses and differences, one that works for us, not against us. And guess what? Charles Drew University, being simultaneously a historically black college university and a Hispanic serving institution, ought to be ground zero where this new way of thinking about multiracial, multicultural society comes from. Dave, that's a real opportunity.
Well, thank you, David. Next is Catherine Haynes. What role do closely focused community-based organizations and institutions like CDU play in reducing health disparities?
I think they're hugely important. First of all, I would say that we have focused a lot on the healthcare system and regulation, but the third lever is people, the people who use the health system. And I think that organizations that have organic relationships with the communities whose lives we're trying to improve are perfectly positioned to do what we learned. And California Healthcare Foundation funded a study called Listening to Black Californians, and it included multiple pieces, including a survey of over 3,300 Black Californians from like age 18 to 86. And what they wanted was community-based education, not on health conditions, but on how to navigate the healthcare system. And they wanted community advocates. Charles Drew and community-based organizations are perfectly positioned to answer that call. And specifically, one of the things that I'm working on is trying to work with organizations to be equipped to do that. Because I have to tell you, nobody knows about the healthcare system. And I've been working in healthcare for, as my grandmother would say, 50, 70 years. And a family member has just been diagnosed with dementia. And I am trying to figure out how to navigate coverage. She has Medicare, but she maybe could be on Medicaid. I am trying to figure out how to navigate and advocate for her, right? So we need help, and community-based organizations who are trusted already are in the position to get up to speed, and so I would admonish them to get up to speed on how to navigate the healthcare system, both providers and the insurance system, so that they can walk hand in hand with their constituents to help them wrest out of the system that is there to serve them the services that they should get.
Indeed, Catherine, thank you very much. Next question for Mr. Becerra. In contrast, you've managed the nation's health and well-being at a macro level. What discoveries about systemic disparities did you make during your tenure as secretary?
I think Catherine hit on something. I mentioned to you earlier that during COVID, we went to where you were instead of waiting for you to come to us. That's speaking to the communities and what they need. They need to understand what they have available because they've never had it available to them. All of a sudden it's there, and they're trying to figure out which is the best. And sometimes they need some help because they're not as experienced. Some of us came from families that never had health insurance. So all of a sudden you're given a choice. It may take a while. We did the same thing with healthcare coverage. Today, there are more Americans who have access to a doctor or a hospital than ever in the history of the country, more than 300 million Americans. We've never reached those heights. President Biden made it possible for us to go out and get you. And today, we have, over the previous administration, we doubled the number of Americans who have health insurance coverage through the Affordable Care Act, through the private marketplace. They were, yeah. They actually lost people during their 4 years. Under the Obama presidency, we reached over 12 million people. By the time we came in, it had dipped under 12 million. We're today at about 24.5 million people who have health insurance strictly through the marketplace. We also increased the number of Americans who have access to health care through Medicaid, through Medi-Cal in California. So today, we get to more than 300 million. But the real success is what Catherine said. We put about $500 million into boosting the number of navigators in the ACA program, so that when you call in and say, well, I see there's 10 plans, I'm not sure which one, the navigator can go through the process with you. What's your income? Where do you live? What do you need? And so then they can make the right choice. So it shouldn't surprise you that people started selecting. You know, they want insurance just the way the rest of us do. And that's what we did. We were intentional in going to where they were and giving them what they needed. Sometimes it would be, well, explain to me what you think I would need if my conditions are so-and-so. But sometimes it's just, well, tell me where the facilities are that I'd get to use with which insurance policy, whichever I choose. At the end of the day, they'll make a good decision. They just have to have some help navigating the process.
Thank you, sir. And now as we go into our second round of questions for the panel, let me remind our audience that you will have a chance to ask questions of the panel very shortly as well. So think about what questions you might have in mind and get them queued up and ready to go. The next question is for Dr. Braveman again. If you could implement one major policy change today to address health disparities, what would it be and why?
Well, first I'd object to being asked to suggest just one change. Because, we all know that it's not the way change occurs. You have to change things on multiple fronts. And yet we measure, we implement a program, and then we evaluate it, and it doesn't look like a success because we didn't put in place also at the same time the other programs that were needed, and then we say it's a failure. So, so I would refuse. But, but since I have the microphone, at the top of my list of the initiatives that I would put in place if I had a magic wand, it's a healthcare crowd, and I'm a physician, and so it's not what you'd necessarily predict, I would say, but it's early childhood education. Because I think the science is really there that shows us what a difference it can make. I mean, the studies have been done, including MRIs of the brain, and show differences in brain architecture in children who have participated in early childhood education programs versus those who have not. Differences in brain architecture that correspond to differences in brain development. There's also the social development that takes place in those programs. And then when a kid has the preparation of the early childhood development program, then they're ready to learn in K through 12. And since I said I wouldn't accept just one change in one area, say the early childhood education, and then K through 12. I would say that's absolutely essential. And then I would say housing, that you need to have initiatives for affordable housing on a massive level. Actually enforcing voting rights, I would put in that, that basic bundle of programs, which, unless we do all of those things, I don't think we can declare doing any one of them to be a failure. Healthcare, access to healthcare would be on the list, but it wouldn't be at the top of the list, and I think it's because of what the evidence is.
Dr. Braveman, I note, of course, you are a physician, but you didn't list health care or access at the top of the list. You listed things that fall into the category of social determinants, a very important message, especially coming from a physician. But you also spoke to what Mr. Becerra spoke to when he said, it's easier to build healthy children than to repair broken men and women. That's a profound statement also, so thank you both. Let's go on to Dr. Hayes Bautista. The Latino GDP was ranked 5th in the world in 2021. What role does economic empowerment play in improving health outcomes for Latino communities?
Well, actually, there's a history to that. We tend to forget, or they don't teach us. Okay, California became part of the United States in 1850. But the United States didn't just conquer territory, it also acquired a growing economy at that point. For nearly a century, Latinos have been carrying on business of various sorts in California, and even after the conquest, in spite of attempts to slow it down, such as confiscating the lands from the rancheros, making illegal certain occupations, such as the street vendors. We're always trying to illegalize them, yet they bring fresh food into otherwise food deserts. In spite of all of that, the Latino GDP has been growing, along with the Latino population. We started tracking this in 2015, and then along came COVID. And right before COVID, the Latino GDP was the 8th largest in the world, which is pretty good, top 10, just right out of the G7, but top 10 GDP. Very fast growth rate. Boom, along came COVID. And COVID hit minorities, people of color, far more than it did other populations, and especially just walloped Latinos. In 2020 and 2021, for Latinos, COVID was the #1 cause of death. Okay, that's about communicable disease and lack of access to health care. Nonetheless, during COVID, the Latino GDP skyrocketed, largely because Latino workers and farm workers in Oxnard couldn't shelter at home and grow strawberries. You have to go out to the field. You're interacting with your fellow workers, the contractors, packing house workers, transportation, the truck drivers, the food chain, the people that stock the shelves. All those people that work in the food industry had to expose themselves to co-workers or to clients. Thus, their levels of exposure and later COVID illness, hospitalization, and death skyrocketed. But they kept working. They paid a price. Nonetheless, the Latino GDP from 2019 to 2022 skyrocketed to $3.7 trillion, was the 5th largest GDP in the world, larger than the entire country of India, and it's right here in the United States, and had the fastest growth rate, faster than China during COVID. COVID did not stop the Latino GDP, but it did suck some of the nutrients out. We've done projections that COVID, while not slowing down even Latino GDP, managed to suck about $250 billion out of it. So we could have been even bigger, but for that. So there's growth. Now, just recently, we released the Latina women's GDP, just a few months ago. We're curious, how do Latinas compare in this? Well, it turns out in almost every metric for the GDP, labor force growth, labor force participation, education, Latinas were roaring past their non-Hispanic white sisters at a rate of 2 to 3 to 1, and 20% faster than the guys, than male. I mean, Latinas are the hotspot of GDP growth for the past 5 years. And at the same time, they were giving birth and raising the labor force for California for 2090. These kids born 2023 will be working in 2090. So they simultaneously supercharged the Latino GDP while preparing the labor force for 2090. What are we as a society going to do to actually boost that? Just think if they were to increase even more their educational and health levels, how much more productive that would be. And we've done this for Latinos. We could probably look at a black GDP, the Asian GDP, we will see very similar trends. By 2090, 75% of the workforce in California will be what we used to call minorities, only when it's 75. I mean, 2/3 is like a super. What is 75? You know, Whopper or something? I don't know. And are we making the investments in those children, in their families, in their mothers, so that they can be as productive as possible? We are the last chance for the United States to maintain economic preeminence throughout the 21st century in those little kids you're seeing out in the kindergarten yards here in Los Angeles today. What a wonderful opportunity.
Thank you. For Catherine Haynes, your background in futurism and design thinking is more important now than ever. How do you envision the future of healthcare delivery in addressing health disparities, and what changes or innovations should we be preparing for?
You know, I came from a background also in advertising and marketing communications at Apple Computer long ago before healthcare. And we just called it consumer research. But what I think we need to do, if I were queen of the world, is remember that we are humans. We are humans as providers, we are humans as patients. And I think that if we are going to come together, we need a diverse group of thinkers to come together and focus in on how people live, how people move, how they interact, where they are, to your point, so that we can construct a human-centered healthcare system. It is not human-centered for doctors. I'm sorry, David, it's not even human-centered for physicians in training, right? So how do we can use design thinking to understand how best to structure the environment of health education, health care, so that it actually serves the people who are rendering care and the people who are receiving care. And through that, I think we would find a lot of differences. There would be room for relationship building, right? Distrust of the healthcare system comes from bad experience. The healthcare system is not going to fix trust by saying, trust us. It's only going to fix trust by changing the experiences of people, and it can only do that if it begins to stop it sort of was developed in a production, industrial revolution context that was geared on efficiency. Efficiency is important. If we're not efficient, we can't serve as many people as we'd like to. But how do we cross that line? And I would use futures between efficiency and human-centered design. And so I would look at all the drivers of change and the signals that are out there of change. A signal of change is something that happens, it's an innovation, it could be very local, it hasn't gone to scale yet, but it has the potential to go to scale. An example would be in the San Francisco Bay Area, we used to line up in the 80s close to a freeway on-ramp and get in a stranger's car to go over the Bay Bridge, because then it would be free and you got to go in the HOV lane. That's a signal. What's it a signal of? It was a signal of Zipcar, ride sharing, Lyft, right? And so we would look for the signals of change in how care is delivered. We may not like it, but Amazon bought One Medical, that remember when Walmart was doing care in its facilities. We need to look out at the signals of change, where things are working. Sometimes it's out of our country, like maybe in Cuba. And design a system that works around human needs, human impulses, human strengths, and human fears.
Wonderful, thank you. Last question is for Mr. Becerra. What role should the federal government play in ensuring healthcare equity, and especially in the context of the current administration?
You threw that curveball there at the end. as I know what role the federal government should play. I'm not sure I expect it to come out of this administration. I have to do my civics lesson here. Please remember, as involved as the federal government is in healthcare, Medicare for seniors, Medicaid for more than 80 million people who are lower income, the Affordable Care Act marketplace, there's nothing in the U.S. Constitution that gives the federal government authority over healthcare. That is a state prerogative. And so all that we do in health is driven first and foremost by the states. That's why we have such a broken healthcare system, because it's not a national public health system, it's a nationwide public health system that depends on how 50 different places do it. And so when you ask, what's the role of the federal government? Well, the reason Medicare has succeeded, the reason Medicaid has succeeded is because we put money in the game. If it weren't that the federal government pays for half or more than half of the Medicaid costs of that low-income family, the states might not buy in. If it weren't the fact that you and I and every one of us who are going to get Medicare have contributed over the course of our working career into it, and then the federal government chips in as well, probably those providers wouldn't take your care. Because remember, in 1965, before Medicare got launched by Lyndon Baines Johnson, seniors would retire into poverty. They didn't have any kind of retirement, whether Social Security was there, but still kind of low, but they had no health care. And so the federal government absolutely has a role, but it essentially has to bring money to the table in order to get to steer where we go. And that's why today things are so dangerous for Medicaid, the Medi-Cal program, because this administration is talking about cutting billions and billions of dollars from a program which we've proven gets people the health care they need. And so it's very, very dangerous. We did something that, again, tries to move us in the right direction away from just curing illness, when we realized, to the point made earlier about the high rates of maternal mortality and morbidity in this country, especially for Native American and Black women, we changed Medicaid. We challenged states. We said, today, Medicaid, you are able, state, to offer 60 days of care postpartum to a woman. So once she's delivered her baby, you and baby will still qualify for Medicaid. Even if your income has changed, we'll still let you stay on for 60 days, which is pretty good. We changed that and we said, no, the data shows us that for many of these families, these women are dying in their 4th month after delivery, or they're going through some really mental health strain, severe mental health strain throughout the course of being a new mom. And so we said, we will cover most of the cost, state, of you extending the care not just for 60 days, but for 365 days for that new mom and her baby. And today, about 48 states have bought in. There's still 2 states. Arkansas, I know for a fact, a woman governor who said they don't need it for their women, but 48 of the 50 states have now adopted Medicaid postpartum care for 365 days. So we can do things.
Well, now it's the time to turn things over to the audience. And so think about those questions, and I would only ask that in asking your question that you direct it to, as much as possible, a specific member of our panel. And I think we have a question here. Yes, please stand up and go ahead.
This is actually, thank you. Okay, this is actually a question to Mr. Bautista. I happen to be a Latina, and my question is, why does it take so long to put into practice what really works based on research? And how can I make a difference? I hold a degree. I grew up here in East Los Angeles, was very fortunate to receive a scholarship at 16 and go to college. Completed a bachelor's degree in biochemistry and dietetics. I have a master's in education organization and was a school principal. I have a doctorate degree in organizational management degree. I am 70 years old. I do not wear glasses. You see me, I am fit. My health is awesome, thanks to God. But I want you to know, Mr. Bautista, and I want to know everybody else, is that why is it that we don't put into practice what we know based on research. And my research is based on 50 years ago. I implemented all these things I learned 50 years ago. And now I see it all, and I'm like saying, you know what, I can almost be a case study. So how can I make a difference? How can I contribute? How can I be, write a grant or do something? Furthermore, I was able to send 4 children to college, and not just any college, all private schools. 2 to USC, 1 to Laverne, and my daughter graduated from Johns Hopkins, and that's why I'm here. She got discouraged at Johns Hopkins not to become a doctor. And I said to myself, you know what? Anyway, I was just passing by. I'm a guest today. I'm just passing. But I want her to come back and finish her doctorate degree and make a difference. But sometimes we don't know this information. And it's just like me. I'm here standing alone. Everybody sees me and they think, sometimes they think I'm just the babysitter. And that's not it. But I'm not here to criticize. I really want to make a difference. I think I am legacy. I've done a lot of things what we're talking about. And I really believe in health. I believe that it's, your body, your mind, and your health have to be together. It has to work together. So if I can, maybe someone here can hear me out, I want to make a difference. Let me know how.
That's wonderful. And there are many, many ways that we can start to take what we learn in the halls of academia and bring them into practice. And you just mentioned some of them within your own family, within your community, within your faith community. And we all have a way to help speed up the adoption of these findings into policy and practice, which is, first of all, if you are eligible, register to vote. Secondly, if you are registered, show up and vote. And thirdly, if for whatever reason you are personally not eligible, find a friend or a family member who is, take them to register, make sure they vote. That's available to everyone. We don't always use it. We don't always understand, just my vote doesn't make a difference. Just a few thousand votes are making a huge difference today. Just a few thousand. So we have many ways to do it, and if you want to discuss more, please come and see me, but we all can have a hand in the change.
Thank you. I think we have a question here. Mr. Baucus.
Yeah, thank you. This will be for Secretary Becerra. You'll always be Secretary Becerra, by the way.
Our secretary, right?
Yeah, right. So, Mike, it's really a statement, and I'd like your reaction to it. I think one of the flaws that we built into our system occurred 60 years ago when we created Medicare and Medicaid. Medicare was a program that was done at the national level. Medicaid was a program that was done as a split between the states and the feds. And today we have a horrible disparity between what Medicare reimburses providers for and what Medicaid does because of the role of the states. I realize the challenge we have in front of us now is to preserve what we have. But why don't we start thinking bigger, and maybe it'll take a generation to get there, to move Medicaid to a national program and have parity in the reimbursement for providers in the safety net, whether they're seeing a Medicare patient or a Medicaid patient. I think that disparity in payments is one of the reasons our safety net providers, not only in Los Angeles, but across the country, are hanging on by a thread. And if we had parity in that, it would also relieve the pressure on the commercial insurers to make up the difference when the hospitals and doctors negotiate with them to say, look, I got to get some balance in my income here. You got to pay me more than those guys. Is that a realistic possibility? I know we can't do it in the current environment, but shouldn't we think ahead and have a longer-term plan on how we're going to get to a more balanced system?
John, there's a very straightforward answer to this, and actually, Dr. Hayes-Bautista just gave it to you. Let me explain. This week, yesterday I think it was, right, the House of Representatives voted on a budget which included, as I mentioned, cuts to Medicaid, not Medicare, Medicaid in the hundreds of billions of dollars over the course of time. They didn't touch Medicare. They went after Medicaid. The reason it's easy to go after Medicaid, and Medicaid, as I mentioned, has more than 80 million people in it. Medicare has about 67 million people in it. But yet they're still willing to touch one of the programs that has more Americans in it than the other. Why? Because most of the people in Medicaid are children, can't vote, or older, lower income folks, many, to David's admonition, don't vote. And so the risk politically to those who are cutting Medicaid is very small compared to the risk of touching Medicare. Because most of those Medicare recipients are seniors, still majority white, and they vote. And I will tell you, we tried, when I was in Congress in 2008, 2009, 2010, when President Obama came in, the effort on what we now know as the Affordable Care Act, many of us pushed at the beginning for what we called Medicare for All. Your exact point. Make the program Medicare, but not just for those 65 and over, but for everybody. Do Medicare. We know it. We've seen it. We live it. Let's just do it for everyone. We couldn't get there. Why? Because of the lobbying of some of the big players in healthcare who didn't want to get that there, and also because politically, the votes we couldn't get because not enough of the people who cared about boosting Medicaid so it could get better reimbursement similar to Medicare, we couldn't get the populations to see the value of that, and therefore we couldn't get the politicians who voted to see the value of that. And so these are all pretty straightforward. And to the question about what can we do if we have an opportunity because we're professionals and we have the spare time, Dr. Hayes-Bautista is absolutely right. If we could just get people who are impacted to vote, their interests, their economic interests, we wouldn't be seeing what we see today in Washington, D.C.
Thank you. I think we have time maybe for two more questions, a few more questions. We have one in the back here.
One here, and I think one up here.
Good morning. My name is Dr. Luca Barnes. I am community faculty at Charles Drew University of Medicine and Science. And I did all of my early training in early childhood education. And the other day, Congresswoman Maxine Waters said that they want to dismantle or get rid of Head Start. And so I've been heartbroken and worried ever since I heard that. And I was wondering, do you think that it is possible that they will get rid of Head Start? The Doris in the middle.
Who do you want to answer your question?
The secretary. Do you think that they will get rid of that program?
So there are efforts to remove those programs right now. Head Start is about an $800 million program that, by the way, doesn't provide access to early childhood education for every child in need who could qualify. All the families who would qualify don't have a place because there aren't enough slots. But it is a tremendous program. In fact, we changed it during my tenure so that we would actually boost the wages of the teachers in Head Start, because you could right now make more money flipping burgers than teaching the next generation of leaders that David Hayes-Bautista is talking about coming in the 2050, 60, 70, and 2080, 2090. And so we wanted to improve its performance so that every family would go to their congressperson and say, you got to boost funding for Head Start, not cut it. We'll see if there's enough political support for Head Start to save it, but at the end of the day, it's going to be whether or not that politician feels like they're going to get too much heat if they vote to cut the funding for Head Start. If those families that use Head Start were to be voters, I think it'd be very tough for any politician to try to get rid of Head Start.
Thank you. And we have a question here. Yes.
Yes. My name is Raman. I'm from Silicon Valley. Just this for Dr. David Carlisle. The biggest disparity is going to come in digital disparity, in particular artificial intelligence disparity. the thing is, one of the things in navigating the healthcare system, AI agents can help tremendously well. So I think one of the things is that we cannot miss that opportunity, particularly in education side. The AI, and then my son, who's of a mixed race, is building an AI agent for create for the food, for the nutritional food for the small community in South Carolina. So I think AI can play a very huge role, and we cannot miss in that discussion. How can you incorporate Dr. David Carlisle in the education system, and particularly for the minority education system?
Well, thank you. And although you directed the question toward me, I'll actually redirect it. Thank you to any one of our panelists who want to take this on.
Summarize the question. AI.
Yes, AI.
How can we make use of AI in schools?
Catherine.
First of all, you should know that in healthcare, there's a lot of work going on looking at the impact of AI and the opportunity of AI in healthcare. How many of you had ambient scribing during a healthcare encounter? Yes. So it's being used primarily right now to reduce that burden, the administrative burden on physicians, so that they're afraid they're going to have to see more patients, but that's an issue to be dealt with. But I think that the Institute of Medicine, for example, has a working group that is looking at, first of all, they've created an AI code of conduct. They're looking at the implications of AI for the workforce and education, integrating education into medical training, not just for physicians, but for nurses and other healthcare professionals, is very vibrant at this moment. At the national level, certainly, and also like in California, Northern California at universities. So that train has left the station. I think what we need to understand, again, going back to the fact that we're humans, is how to deploy AI in a way that augments the human capacity. It will displace some people, but it also means upskilling existing workers and freeing up their time to do tasks that are at the higher level of their skill set. And that information and that effort is ongoing. We are also, at California Healthcare Foundation, have an impact fund, innovation fund, where we do invest in companies that are using AI. Again, primarily we're investing in those companies that are using it for back office or administrative functions. But it will come into both the delivery of care more robustly in decision support, for example. And there's Doris Duke Foundation is actually looking at bias in clinical algorithms. And the intersection between that work, the work of Doris Duke Foundation, and AI is that we do not want AI to be trained on biased clinical algorithms. And so there is work to eradicate the bias. In some cases, it's easy because it's the application of the decision support tool, like creatinine and renal failure, using a different scale for me than for you. But there are other areas in which we really have to re-engineer the algorithm, and that will take longer. Doris Duke Foundation is funding sort of disease societies to do that kind of research. In the interim, we need to make sure that we fight the good fight and keep bias algorithms out of the tools, clinical tools that we're delivering, that we're developing for clinical care in our delivery systems.
And Mr. Becerra has a response also.
Yeah, just wanted, and Catherine touched on the point I was going to raise, and that is the algorithms. AI, just like the internet, just like social media, these technologies, once they hit the ground, you know, the Pandora box is open. You can't push them back in. The genie's out. So it's going to be there. And it can do some really great things. It can accelerate how we can get information, how we can get things done, et cetera. But there's some downsides too. If it's going to knock you out of a job quicker than you expected, and there's nothing there for you to fall back on, that can be very dangerous. But what I would say is this: let's not make the mistake with AI and with things like cryptocurrency that we made with the internet, and that is to wait, to let it blossom and show us all the fruits of its, what it brings to us, and then let it get out of control. And we know we have to have oversight, and we have to have some regulation if that's going to exist, because I guarantee you those algorithms are not written by most of the folks who look like us. And so you need to make sure that whatever AI is doing, it's not excluding you from the get-go. This is where I go back to what I said before: equity by design. We got to make sure that whoever these companies that are going to put AI out there, that they can show us that they didn't have an institutional bias against communities, that they are not forgetting certain people, that they are incorporating the rest of us, so that when it's out there churning all this data and results, we were in there as well.
I think we have a question here from Dr. Abraham.
We have about 10 minutes for questions, so we just ask you to help us out by keeping your questions succinct. We have a question here, and then we'll move to the front, if that's okay.
Good morning, everyone. I'm Tia Delaney Stewart, and I was going to talk about something else, but as a registered nurse, the thing that I heard the most when we talked about statistical data and academia was what I heard was Catherine Hayes had a mom who had dementia, and she needed help navigating our system. I happen to be the Director of Diversity, Equity, and Inclusion for the Alzheimer's Association. I'm also a registered nurse with the Council of Black Nurses, and I sit on a lot of boards. But I really just wanted to say to you, I am here to help you navigate the care for your mom. That's what I heard first. That's what I heard first. So I wanted to make sure that we connect, Catherine.
Thank you.
My question to the panelists is, we know that in the last decade, our aging population over age 65 has increased by about 35%, right? We also know with Alzheimer's disease and other dementia, with every 5 years after the age of 65, your risk for developing Alzheimer's disease and dementia increases. We also know that Black African Americans suffer through those risks twice as much than white Americans, and Latino Americans 1.5 times as much. So here's my question. Why is it that when we think about Medicare, Medicare does not cover hearing aids for folks 65 and older who have Medicare? But we know that if you wear a hearing aid, you reduce your risk for developing dementia by over 40%. So where are these silos? My other question is, we just came up through CMS with an amazing program called GUIDE, G-U-I-D-E, and it stands for Guiding an Improved Dementia Experience. And it's for people who have Medicare, but not for people who have Medicare that's attached to an HMO, like a Kaiser or a SCAN. And we know in the last 10 years, all those health plans came into our communities and had our seniors sign up for an HMO like Kaiser and SCAN. So now we have an amazing program designed to help people navigate that dementia journey that they can't have access to. So all of these things are fabulous. And so my question to the panel is, we have fabulous silos. What are we doing to work together to remove those barriers? The people in the community cannot do it. It's up to us. We have to have the accountability and the responsibility to do so. We cannot continue to have these single trains going to help our community members, but they're not meeting up in the middle where the people need them the most. So I don't know who to direct it to, but I wanted to direct that to you, Catherine, and my question to the panel. Thank you.
Thank you. Who wants to take a question?
Can I put another layer on that question?
Yes, yes.
Because in California, we have something called CalAIM, which is California, Advancing and Innovating Medicaid, Medi-Cal. And it has a lot of services. It has enhanced care management and community supports. And it dawned on me, because my portfolio, Black Health Equity, it's agnostic about insurance. In commercial insurance, you don't get that, right? So how, I'm adding another layer. How do we take the best from all places and put it together?
So CalAIM is what we call in the Medicaid world a program, a state-based program that seeks waivers from the traditional Medicaid program. We granted California that waiver, which now lets California use its Medicaid dollar for more than just the reimbursement of a Medicaid doctor or a Medicaid hospital. Now you can use it, if the state chooses, for dental services, for hearing services, vision services. You can use it for transportation, so long as you can prove that by using that dollar for something other than to reimburse the doctor or the hospital, you're actually improving the health status of that Medicaid recipient. That was what we did to expand to the social determinants of health, how Medicaid can tackle this. But I'm going to return to, once again, what you won't like, the Byzantine world of Medicare, Medicaid. I tried, while I was secretary, to add dental, vision, and hearing services to the Medicare program. We couldn't get Congress to support. You have to do it by statute. Because of the way the Medicare laws are written, we needed Congress to change the laws to make them more flexible. We can't get there principally because it costs more money, even though it saves money by getting people access, as you just mentioned, someone who's a nurse. So what I will tell you is what Dr. David Hayes Bautista said is probably the most profound thing. Actually, I think Dr. Braverman said it as well. It's voting. It's getting these folks who are making those very important decisions to make the right ones. Because Congress could immediately make folks in Medicare eligible for vision, dental, hearing. They just have to vote for it. We don't have the majority yet to do that. And that's the difficulty that we face, but certainly we could get there. And hopefully folks are going to register after this.
Indeed, indeed. Yes.
Thank you so much. Happy Black History Month, of course. And Jerry Abraham, street medicine physician at Kedron, a historically black psych hospital and federally qualified health center in
And former
South LA.
president of the LA County Medical Association.
Thank you, yes. And I'm also proud to be faculty at Charles University in the departments of family and community medicine as well as psychiatry. I serve on the board of the California Black Health Network, and I really want to commend the California Healthcare Foundation and Catherine Haynes for your leadership, continued and sustained support of black health equity in the state. We also applaud John and LA Care, now Martha Santana Chen's leadership when it came to Medi-Cal and making sure that that's a sustainable program with Prop 35, for example, those new dollars. I really appreciated the remarks from Dr. David Bautista Haynes, specifically the successes that we're seeing in Latino health. I worry we live in different Americas, and I'm worried that the road that we're on is very different, the Latino health road and the black health road. And so how do we have strategies that advance and achieve equity, close these gaps in disparities, understanding that we're going to need very different strategies for the Latino and the black community. And Dr. Braverman, if you would like to answer or chime in based on your research, but anyone else, of course. Thank you.
Well, the first step is realizing that there's a question there. That's a big deal, even in itself. I think that there are some things that aren't questions. They're answers, like the voting. I think that there's also, another answer, not a question, is, finding ways to get input from the communities themselves about what's needed, what's unmet in terms of needs.
Catherine and then Mr. Becerra.
I would really, if I were an anthropologist, I would really want to look at the cohesiveness of communities in the two different groups that you mentioned, and what's happening in particular to community, the fabric of black communities in the United States, to understand this other factor, which is cohesive social community and social support and what role it might play. Because I think there's something there. That's
Indeed. Javier.
And I think David has to comment on this one, but I will say this. I don't think the differences are as great as you might think, because if you think about it, we essentially live in the same neighborhoods. And so access to the resources isn't difficult for both communities. Now, there are some differences. I will say one thing. I have, on more than one occasion, said to some Catholic bishops and priests, why can't you take a more activist approach the way the Black church does in the Black community? To give guidance, not just spiritual guidance, but help them figure out where to go get that COVID vaccine for free. I mean, I think one of the things that is a powerful institution within the Black community is the Black church, because it's always been a part of the life of Black families beyond just spiritual, religious understanding. And I think the Catholic Church, which is a behemoth, I mean, the size of it, but it just almost as if it's afraid to advocate for the people who sustain it, because most of the folks who sustain the Catholic Church in the U.S. are Latino. But do you hear them advocating for all these immigrants who are now scared to death as actively as the Black church stood up when Martin Luther King was talking about civil rights? No. And so I think whether we like it or not, we're in the same boat. And we happen to have a lot of the same demographic characteristics and conditions. Diabetes hits both of us really hard. Dementia hits us both very hard. Access, economics, when the downturn in 2008 came, the economic crisis Wall Street created, who got hit hardest? Black and brown. We lost so much of our wealth when we lost our homes. And so we're in the same boat in that sense. So it wouldn't be difficult to make sure that we lift all the boats by doing some things. So when we did the maternal mortality and morbidity program to try to help postpartum care mothers and babies, it was principally to help Black and Native American moms. But there are Latina mothers and babies who are going to benefit from that as well. What we need to make sure is that there is never such a drop, that the bottom is never so deep that there are certain communities that are always at the bottom. And that's what we want to do, is make sure we raise it. Because you know what? We've proven over time, you give us a chance, Black, brown, actually anybody, we'll make it. We don't need you to be there for us all. Just don't get in our way.
And David, I think Dr. Abraham started out with you, and so we'll end with you. Go ahead.
Well, I just want to point out once again, I always say, never let a good crisis go to waste. They also represent opportunities. And in particular, we have here the only HBCU that is simultaneously a Hispanic serving institution. What better place to get our arms around these issues and provide leadership for this country?
Well, I think we're just about done, but I want to end with a lightning round of fill in the blank. And the fill in the blank is simply to ask our panelists, are we better in terms of disparities today than we were? And we'll give you 20 seconds to answer that question. Mr. Becerra.
I'm the son of immigrants, so optimism runs in my DNA. So we are better off than we were before, and we will be better off because we're going to change it, because we're ready to be in that starting five.
Thank you. Professor Braveman.
The data say that we're better off in terms of coverage, but we're worse off in terms of life expectancy. We were making some gains in life expectancy for the 10 years or so before COVID, but then COVID just really exacerbated the inequities. And now we have a national government that is really going to exacerbate the inequities, so we're going to have to redouble our efforts.
Thank you. Professor Hayes-Bautista.
One of the benefits of being the oldest dog in the room is you get to see things go back and forth and back and forth. but you can inch things along so that each swing moves along a different arc. So we have seen this before in this state. Every 20 years since we've been part of the U.S., we've had these nativist backlashes, but we also make some progress. The important thing is to learn we make more progress together than we do alone.
Catherine
I
Haynes.
was going to say what Dr. Braverman said. However, what I am going to say is that we in the state of California are in an amazing position because all of our state agencies are lined up together. Covered California, the Department of Public Health, the Department of Healthcare Services, which oversees Medi-Cal, Department of Managed Healthcare, and HCI, which used to be OSHPD, and I can't remember what it stands for, but
Healthcare access and information.
Yeah.
Healthcare access and information.
Healthcare access and I'm showing my age. All of those organizations are speaking together. The heads are talking to each other about health equity and about reducing disparities, and they are aligned. And so I think we have made strides in infrastructure. We have moved from thinking about individual disparities and diseases to thinking about comprehensive equity in a system. And so I think that even in tight times, we are in a position to lead in the state of California, and we have the expertise and knowledge and will to do it.
Well, there you go from a panel of world preeminent experts on the topic we're talking about. So at the end of the day, closing the gap on health disparities hinges on one critical human quality: empathy. You can't teach empathy, unfortunately. Empathy is kind of inherent. It's developed through lived experiences, through struggle, through community. CDU students embody empathy. They enroll at CDU and learn to use and channel their empathy. And when you're surrounded by empaths, it's much harder to feel like an outsider. Imposter syndrome can't touch you. And that's the difference that CDU makes and why CDU is a place worth investing in. As more and more federal programs, revenue streams, and programs are threatened, I hope you'll stand in solidarity and partnership with CDU as we recommit to our work in health equity and social justice. Thank you for joining us this morning, and we'll see you next year.